Good morning. I'm Mohammad. Majd. I'm an orthopedic spine surgeon at New Albany, Indiana. I'm clinical professor with Indiana University, and my talk is retrospective analysis of sacroiliac joint fusion, comparing the percutaneous transgluteal approach to the posterior oblique approach. I don't have anything to disclose. Our study design is we are trying to compare transgluteal approach with posterior oblique approach. And we try to answer those questions. We want to answer to see is there a difference in the post-operative pain score. We want to see is there a difference in the post-operative revision rate, and is there a difference in the complication rate? Is there a difference in the amount of intraoperative blood loss? And can any predictive factors for successful outcome be identified? And is there a difference in the post-operative management after completion of the surgery? As all of us know that sacroiliac joint pain incidence is between 13 to 30% based on many studies. Etiology of sacroiliac joint pain is degenerative sacroiliitis, traumatic sacroiliac joint disruption, seronegative spondyloarthropathy, infection, iatrogenic adjacent segment degeneration following lumbar fusion surgery. And in all of those patients for diagnosis, basically we do provocative test. And if the provocative test is positive, at least 3 of the tests from 5 tests, we send them for injection. Overall, the traditional sacroiliac joint fusion that we used to open the joint. This is an algorithm for treatment of sacroiliac joint. If we diagnose the patient with sacroiliac joint pathology, normally, basically, we do the clinical evaluation. If our diagnosis go towards to sacroiliac joint pathology, we send them for sacroiliac joint injection. If the patient get greater than 50 to 70% of pain relief, in this group of patients, we give them 4 weeks of physical therapy, NSAID. And if the patient continued to have pain, basically we give them another sacroiliac joint injection. Again, if the pain get better, more than 70%, basically we proceed with surgical intervention. That currently the trend of treatment is minimally invasive sacroiliac joint fusion. If the pain is not getting better or is getting better less than 50%, we have to evaluate the other source of the pain. Basically, we have to evaluate the lumbar spine, we have to evaluate the hip joint, and also we have to evaluate the lumbosacral plexus anterior to the spine and pathology that involve the psoas muscle and the area anterior to the spine. And if the pain is not getting better, basically we have to continue to evaluate them and then continue conservative modality of treatment. Those cases are not good. They are not a good candidate for sacroiliac joint fusion. With transgluteal approach, the direct lateral approach, we do percutaneous dilatation of gluteal muscles, drill, tap, and implant over a guide wire. Normally, we implant 3 impacted implant across the sacroiliac joint, and those implants are triangular porous coated for bony ingrowth. In posterolateral approach, the beauty of that approach is we are eliminating the gluteal muscle totally. The approach starts from the lateral aspect of PSIS. Then if we do the C-arm, we go with the inlet and outlet posterior oblique view. And currently that we do the O-arm and navigation, that is very easy and straightforward, that we can see the joint and we can put the implant through the joint. But if we use a C-arm, basically use a guide wire, drill and tap, and normally we use 2 cannulated screws that each one of them are 12 millimeter in diameter, is hollow, pack it with a bone graft substitute, and then implant the device. In our studies, retrospective single cohort study, inclusion criteria over sacroiliitis, SI joint disruption, exclusion criteria, revision of sacroiliac joint procedure, and all other sacroiliac pathology. Cohort A, in cohort B, the number of the patients. We evaluate the pre-op VAS, post-op VAS. Post-op VAS score is stratified to 3 groups. Group 1, these are the group that the VAS get improved more than 50%. Group 2, between 1 to 49%, and group 3 are the cases that the VAS get worse. Look at the adverse event, look at the rate of revision, complication, and intraoperative. In this 2 table, in the left-hand side, we see transgluteal cohort. 45% of the patient got more than 50% VAS improvement. In the posterior oblique approach, this number is 60%. In the group of 1 to 49% improvement in transgluteal approaches, the number is 35. In the posterior oblique approach is 36.7. No statistically difference. And the important thing is in the transgluteal approach, about 20% of the patient VAS basically did not improve. In this number in the posterior oblique approach is 6.7. We look at the adverse event in transgluteal approach. We had 4 adverse events, 1 infection and 1 hematoma, 1 nerve root irritation, 1 pseudoarthrosis. From these 4 patients, we revised 2 of them. Posterior oblique cohort group, our adverse event was 2. We had 1 seroma, and this seroma was a case that previously had a pelvic trauma, had a screw, and at the time of sacroiliac joint fusion through a longer approach, we took the previous screws out, the patient ended up with a seroma. The infection case was a case that had a coccydynia with a broken tailbone and sacroiliac joint pathology that I did the surgery for both at the same anesthesia. The patient developed infection at the area of the coccygeum. Blood loss in the cohort A was about 60 cc, cohort B about 33 cc, and posterior oblique cohort had 45% loss. What about the post-op regimen? In cohort A, or transgluteal approach, we kept the patient in the hospital for 23 hours, 6 weeks non-weight bearing, and 6 weeks partial weight bearing. In posterior oblique cohort, the observation was 4 hours in the PACU, immediate weight bearing, and send the patient home 3 or 4 hours after. Currently, we do our sacroiliac joint fusion through with a stealth navigation and OR that based on this picture, you see passing the cannulated screw through the joint. And in the top picture, I want to show that we put the first screw and we can aim for the second screw. And on the left-hand side, I want to show that's the incision that we were able to put 2 cannulated screws through that incision about less than 1 inch. So in conclusion, posterior oblique approach is less morbid, lower complication rate, less blood loss, and no revision in my cases. And we need further studies with greater power to be. For revision cases, the cases that we revised, those are the cases that had a transgluteal approach. Based on that picture, you see this patient got a pseudoarthrosis and a halo around the impacted implant. This patient had an impacted implant, and the implant protruded through the S1 foramen, causing nerve root irritation that the patient needs revision. And revision for transgluteal approach can be revised with posterior oblique approach without removing the implant. Implant removal with transgluteal approach is difficult as the implants are impacted initially. And in some cases, we can do a direct posterior approach, may also be possible without removing the implant. For cases with posterior oblique approach, as I said, I haven't revised any of the cases, but overall implant removal is much easier because the implant is threaded. Implant can be removed and redirected via a new posterior oblique approach. Navigation helps with finding new trajectories. And in some scenario, we can do a direct posterior approach may also be possible. This is one of my first patients that I did a transgluteal approach to implant, and the patient developed non-union. And we revised this patient with posterior oblique approach and added 2 new implants. And his pain got. These are my references. Thank you for having me. And I really appreciate for SIMEG committee to put that course together. Okay, Derek, let's see. So when you can pause, yeah. Yeah.